Hello, dear all. Thank you for kind invitation. My name is Rustam Yuldashev. I am pediatric surgeon from Tashkent, Uzbekistan. Our research study dedicated to angiographic patterns of extrahepatic portal venous system in children with prehepatic portal hypertension and its etiological and clinical relevance. Majority of children with extrahepatic portal hypertension have isolated portal vein obstruction, and the portal vein is replaced by multiple venous collaterals, so-called portal cavernoma. And in these children, the portal venous system can be variably occluded. Children often present with splenomegaly and thrombocytopenia, esophageal and gastric varices, and GI bleeding. In 1869, Balfour and Stewart first described the cavernous transformation of the portal vein. More than 150 years have passed since then, and today we have a number of etiological factors that cause this disease. However, even today, in majority of patients, the etiology of the disease remains unknown. The patterns of portal mesenteric obstruction may provide clue to its etiology and clinical manifestation. And we aim to study the relationship between the angiographic pattern and its etiology and clinical manifestation. The inclusion criteria for this study was children under 80 years of age, normal liver function test, presence of portal cavernoma and splenomegaly ultrasound, normal values of liver stiffness according to elastography, and no proposed surgical or endoscopic interventions. The data we studied was age at presentation, gender, etiological factor, presenting symptoms, upper GI endoscopic symptoms, and patterns of extrahepatic portal venous obstruction according to CT angiography. 155 children with portal vein obstruction included in our study. Median age at the time of evaluation was 9 years. The majority of children with extrahepatic portal hypertension had pathological condition in neonatal period, and ophthalitis, musculoskeletal septic conditions, prolonged jaundice, and prematurity were noted with almost equal frequency. Among known etiological factors, umbilical vein catheterization were most frequent. However, in 48% of cases, children with portal vein obstruction in our observation have no identifiable etiological factors. Geography, we defined 5 imaging patterns and named them type 1 to type 5 conventionally. Most frequent types was type 1 and type 2 pattern, where the occlusion of the portal vein in type 1 was at the level of the bifurcation of the portal vein and at the level of the main portal vein trunk in type 2. Both these types had a patent superior mesenteric vein and splenic veins. Least common pattern was type 3 pattern, where the portal vein occlusion was extended to the splenic vein, and type 4 pattern was characterized by portal vein occlusion and superior mesenteric vein occlusion, with patent splenic vein. The worst, from the surgical point of view, imaging pattern was widespread thrombosis of the portal vein, type 5 pattern. When comparing known etiological factors and patterns of portal vein obstruction, it was found that children who had type 1 and type 2 had a higher incidence of umbilical vein catheterization in neonatal period, whereas children with widespread thrombosis of the portal vein system, type 5 pattern, had higher incidence of musculoskeletal septic conditions in neonatal period. According to data, children with type 1 and type 3 patterns admit to hospital significantly earlier than children in other groups. Nevertheless, the correlation of age and the types of portal vein obstruction was weak. According to upper GI endoscopy, children with type 3 and type 5 patterns had the highest incidence of GI bleeding episodes. Although these children had a higher incidence of gastric varices, whereas children with mesenteric vein thrombosis, it has type 4 pattern, never had portal hypertensive gastropathy, and they had a lower incidence of gastric varices. Also, these children had a lower rate of cherry red spots. Additionally, according to upper GI endoscopy, children with type 4 pattern had significantly lower grades of esophageal varices, especially compared to type 1 and type 2 patterns. Thrombocytopenia was a common clinical feature of type 3 pattern, and it was observed in all cases. Nevertheless, significant differences in platelet concentration were found only among children with type 4 and type 5 patterns. In conclusion, common angiographic pattern of extrahepatic portal vein obstruction in children is type 1, obstruction at the level of the bifurcation of the portal vein. Umbilical vein catheterization was more associated with type 1 and type 2 patterns, whereas children with widespread thrombosis had the highest incidence of septic condition in neonatal period. Children with splenic vein thrombosis and widespread thrombosis of the portal vein had the most severe clinical manifestation of symptoms, and children with mesenteric vein thrombosis type 4 pattern is characterized by lower risk of bleeding from esophageal varices and less incidence of gastric varices on GI endoscopy. And thank you for your attention.